while they're coming, I'm going to ask you a question, Dr. Larson. So if I see a patient on Monday morning, newly diagnosed CML, and I just saw the data for the ASPHO first, and I'm all excited, and I want to start the patient on Asciminib, what are the things that should guide me in deciding what patient I should treat with Asciminib?
My first call would be to the insurance company because, as we all know, they dictate therapy these days. Some insurance plans have been restrictive that although Asciminib is approved in the front line, they want to see patients start on a first or second generation drug and either demonstrate intolerance or resistance. I think the only reason not to give Asciminib is that we don't have the long-term data that we have on the other drugs. We have 25 years of long-term data on imatinib and about 20 years on dasatinib and nilotinib. All of those drugs are becoming generic now, so again, the price differential, I think, will dictate what initial therapy patients are allowed to start on.
And by the way, anyone is welcome to come to the microphones, identify yourself, your institution, and ask your questions. Dr. Gurners.
Hi, I'm Thalias Gurners from TriHealth in Cincinnati. Following up on the Asciminib question, or somewhat similar to it, a patient who has failed discontinuation of TKI after 5 years of imatinib, they relapse again, would you challenge them with Asciminib for 2-3 years and see if you can get them off therapy rather than buy them lifelong TKI?
Yeah, so the question is rescuing patients who have failed an attempt at a treatment-free remission. Certainly if they were troubled by side effects from imatinib, I'd think about switching. I think Asciminib is better tolerated than imatinib. The prospective discontinuation trials have generally restarted patients back on the same TKI that put them into a deep remission prior to their attempt at TFR, and almost all of those patients do go back into a deep remission. So I think the fact that the patient progressed doesn't mean they're imatinib resistant. But I think I'd be guided in part by the whatever toxicities they were having with their previous TKI and use that to justify switching. And we've been switching to Asciminib, again, based on its more favorable toxicity profile.
Dr. Bhatia.
I appreciate your comment.
Introduce yourself and identify your institution, sir.
Sumit Bhatia, CHNMD Anderson, Indianapolis. I appreciate your comment about Asciminib, but Asciminib per year costs $600,000, $250,000 to $600,000 versus Gleevec costs $1,000. When you look at the primary endpoints as you go into 15, 20 years, we do not know that achieving molecular remission to a very deep molecular remission results in improved outcome.
Dr. Larson, what do you think?
Especially when balanced against non-compliance. So yeah, how do you rate that for a society?
Well, the economics of treatment of CML has certainly been controversial. The retail price of Asciminib is about $250,000 a year for chronic phase patients. If you're treating patients with a T315I mutation, it's $1 million a year. So it's a very expensive drug. I think there's no patient who could afford that themselves without insurance coverage. But you make a good point that imatinib is $600 to $1,000 a year. We still generally recommend imatinib for the 50% of newly diagnosed CML patients with low risk scores because we think it's very effective and a well-proven therapy. Again, whether Asciminib will eventually move into a priority space in frontline, I think, again, insurance companies will dictate that to us.
All right, I'm going to, Dr. Eckert is going to be next, but I have a question for Dr. Polier and Rami. My question is, you guys talked about the IDH mutant patients either in the first line or when they relapse. You talked about potentially considering doublets. What do you think about a triplet?
Maybe I'll handle the frontline question and let Rami. Yeah, I mean, I think triplets are really interesting in the AML field. People are really doing them a lot. And I think my question is just to think through, the rationale. So a triplet in a situation where a patient has a low chance of getting into a remission, great idea. So here I'm thinking like the MLL rearranged patients, a menin inhibitor with Ven/Aza, great idea. Overcome resistance, improve the response rates. A triplet in an IDH positive patient up front, as I kind of showed, the IDH patients do quite well with Ven/Aza. And so adding a third therapy in the upfront setting, we just have to ask ourselves why. Is it to improve response rates? I think that's a little bit of a tough one. Is it to, on the back end, improve duration of remission? Well, then in that case, should we just be adding it in when if a patient doesn't respond or if they start to relapse and base that on MRD? So I'm not in favor of just widespread triplets, but triplets to overcome resistance or particular being refractory, absolutely. I got the ding on the question.
Yeah. No, that's telling us we have 1 minute left, I think.
I agree. I think the other thing to keep in mind, the only advantage if we can get to a discontinuation again. If we're going to do triplet and then after a year we could discontinue. But I think also we have to think of those, if we're going to go to the triplet way, we have to think of it as an induction, and eventually we have to drop some of those medications. We cannot maintain patients on a triplet ongoing. So it's to be explored, obviously, off trials. We should not be doing that.
Dr. Eckert.
Luke Eckert, IBMT. In the younger population with AML, who should we be treating with Aza/Ven? And also in the younger patient with AML, who should we be treating with aggressive treatment to which we add Venetoclax?
Okay, quick responses.
Yeah, I think Dr. Pillai will tell you everybody gets HMA-VEN. So I think in younger patients, obviously, if they have good risk with a curable intent, we should be doing intensive chemotherapy. That's clear. The other groups, I think it's a moving target. There are ongoing trials looking at intensive chemo versus HMA-VEN. I totally agree with what Dr. Pillai mentioned earlier. Sometimes in the adverse risk, I think sometimes those patients are better actually served with HMA-VEN regimen. In my opinion, like a P53 young patient, even if they are young, they are better served with less intense treatment and trying to take them to transplant.
Yeah, I can't really add much to that except just to say, the route of Ven/Aza, get a remission, go to transplant, is a really good route with some good emerging data that can be an effective approach. And so, as long as that's kept in mind, and like Rami said, just intensive induction for those you can cure, and then maybe Ven/Aza for others with the intention to go to transplant.
So, Dr. Charles, you're going to finish up this session. We're running late, so keep your answer brief. What patients with AML should we be transplanted in the first line?
You're asking a transplant doctor that question. if you go to Midas, you get a muffler.
So you transplant everyone?
Obviously, risk, performance status, transplant factors. If you have somebody that has significant comorbidity, that may factor into whether you bring them up front to a transplant or not. But if you have a high-risk younger patient that should do excellent with conventional transplantation, these are all things that have to be factored into each patient, I think, individually. Older patients, obviously, we used to exclude. Now, as you can see, 25% of patients are over the age of 65. So I think that the patient, besides the disease, is something that has to be factored into that algorithm.